based discussion again on epilepsy in children. Over to you, Saraji.
And I would like to thank Madam Padma Gunaratna and the Council of the SLMA for giving me this opportunity to talk to you on this topic. Let me share my screen. Yeah, can you all see my screen?
Not yet, Saraji.
Can you now?
Not yet.
Not yet. Sorry about it. Yeah, let me see why it's not. Okay, is it okay now?
Not yet.
Something wrong there. Am I allowed to screen share? I'm just wondering.
Just a second.
Yeah.
Vihanga?
Saya කරන්න පුළුවන් madam.
පුළුවන්.
Okay, sorry. Yeah, okay. I think now it's okay, right?
Yes, yes.
Yeah, okay, fine. Yeah. Thank you, madam. So, my topic today is a case-based discussion on epilepsy in children. So, before I will just like to go with the overview of my talk today. So before going on to the case discussions, I thought I will brief to you about what is a seizure and what is epilepsy and how to define epilepsy syndrome. And also a brief illustration of the ILEA classification, which was put out in 2017, as this will be very useful for us to understand what these cases are. And especially when I'm dealing with children, I have to talk to you about provoked seizures, because most of the seizures in children are provoked than epilepsy. So it's a good thing that we have some idea about provoking factors, and then go through the case scenarios. And finally, to go through the questions, select the best response. So what is a seizure? So a seizure is a paroxysmal, a time-limited change in motor or sensory activity or behavior or abnormal autonomic functions. This may occur in isolation or in combination due to the abnormal electrical activity of the brain. So you may sometimes encounter seizures with just behavioral change or some sensory change or autonomic functional change, but also all three may exist in one patient. So all this happen due to the abnormal electrical activity of the brain. Then when it comes to epilepsy, when do you call a patient having epilepsy? So at least there should be 2 unprovoked seizures. That means provoking means there is some factor that is causing the seizure. Especially when I go ahead, I will describe to you that in children, the most likely, the common provoking factor would be fever. So there shouldn't be any unprovoking factors for you to call it epilepsy. So it has to be at least 2 unprovoked seizures occurring more than 24 hours apart. So there needs to be 2 seizures. And even if there is 1 unprovoked seizure, and if there's a probability of further seizures within the next 10 years, supposing if we are dealing with a patient with a syndrome like tuberous sclerosis, we know that even if there is 1 unprovoked seizure, we will have another, we know that there's a probability of further seizures in that patient. So in such situation, we call it epilepsy. And also, if we diagnose an epilepsy syndrome. So what is an epilepsy syndrome? We all know that syndrome is a constellation of signs and symptoms. So here also is the same. Plus we may have our investigations to help us. So if I take an example of a childhood absence epilepsy, the features like the age, the sex, and the clinical semiology of the seizure, like staring episodes and things like that, and plus the investigation of EEG with the characteristic pattern will tell us that it's epilepsy syndrome. So all three, under these conditions, we call it epilepsy. So if you go through the ILEA illustration of seizures, this was put out, as I told you, in 2017. Before that, we had partial seizures, we said focal seizures, and we said generalized seizures. So the seizure types were defined according to the onset here, like whether it's a focal onset or whether it's a generalized onset, or if somebody doesn't know whether what onset this is, then it was known as unknown. So this is very easy in a way because it's very descriptive of the thing that we see. And then, of course, the etiological pattern, whether it's structural, whether it's genetic, infective, or whether it's immune, so forth. Like there are many reasons of the etiology. And then you come into the epilepsy types. Not partial or focal. Those days we call it partial epilepsy. Now we use the term focal epilepsy or generalized epilepsy, or sometimes in one patient we can have focal and generalized epilepsy. So that is a combined focal and generalized. And sometimes, like an infantile spasm, sometimes we don't know the type of epilepsy, like they come with spasms and different other types in very chronic epilepsy. So these are just descriptive terms for easy understanding. And then with all these constellation, you can get an epilepsy syndrome followed by comorbidities. The comorbidities in an epilepsy patient could be a cerebral palsy, or it could be like any other illness or syndrome that they may be having. So if you can look at this ILEA illustration, it is very descriptive. I mean, anybody can, easily say that, okay, this is the seizure type, this is the epilepsy type, and if it goes into epilepsy syndrome, this is that, and then the etiological factors are defined. And also, if you want to term the comorbidities, that is also there. So what is a generalized seizure? Now, generalized seizure originate at some point, right, within the brain, and then it rapidly discharges. If you can follow my figure, it originates from here, but actually it engages the whole brain and distributed among the networks in the brain. So it can include the cortical and also the subcortical structures, and but not necessarily, it doesn't have to involve the entire cortex. So you see changes in the EEG as a generalized seizure, as opposed to the focal seizure, right? This is the seizure onset, and you can see that it may limited to the same side or the lobe that it originates from, or it can be communicated to the other hemisphere as well. So this can be widely distributed as well. So that is the way that the focal and the generalized epilepsies or seizures are classified. So I said we need to know the provoking factors because it's very important. But in adults, if you take, the provoking factors may be slightly different. But in children, when it comes to the intracranial causes, if there is intracranial hemorrhage or any CNS infection like meningitis or encephalitis, a traumatic brain injury, a stroke, or a subdural effusion following a meningitis or for any other reason, and a space occupying lesion like a meningioma could provoke a seizure. And at the same time, metabolic causes like hypoglycemia, which is common with fasting in children because they have a very low liver reserve, and also hyponatremia in diarrheas and any other salt-losing causes. And hyponatremia, especially in young infants, we may, even with dehydration, we will have hyponatremic dehydration, which may cause seizures, and hypocalcemia, hyperammonemia, like a metabolic cause, or hyperuricemia can cause provoking seizures in children. Then, of course, we shouldn't forget the cardiac causes, where we will see seizures in children. They are termed reflex anoxic seizures. Right, okay. With this background, I'm going to go into the first case scenario. So this is an 11-month-old baby boy who presents with a generalized tonic-clonic seizure lasting 2 minutes. He had a temperature of 100 degrees Fahrenheit before the onset of the seizure. There is a history of his sister having a seizure with fever at the age of 2 years. And also, he had an uneventful normal vaginal delivery and a normal postnatal period, so no insults there. And his development age is appropriate for his age. And there's no features of CNS infection on the examination. And however, he had a mild cold and a cough with clear lungs on examination. So what is the likely cause for his seizure? I think this is by far one of the common causes that you may encounter in the wards, in the general practice, or anywhere you do your clinical practice. So what features help you to arrive at a diagnosis? So what is the diagnosis? So it's a febrile seizure because we mentioned certain things in the history, and it's a simple febrile seizure because it lasted less than 15 minutes and it's a generalized seizure, and there's only one episode during this febrile illness. So what are the features that help to arrive at the diagnosis? So the age of onset, it was 11 months. Right? And there was no evidence of CNS infection. Obviously, when a patient of 11 months or less than 1 year coming with the first episode of febrile seizure, you need to exclude your CNS infection. So that means even with the slightest doubt, you have to do your investigations and treat as a CNS infection. And in this patient, there's no past history of any unprovoked seizures. And the family history of febrile seizure in the sister is also mentioned. And there's no history of any neonatal seizures. Why I mentioned that, I will explain to you in the next slide. And also the patient's neurodevelopment is normal. So when you look at the ILEA definition, this is way back. I mean, there are several other definitions that have come to date, but we take this as kind of the definition that we use for febrile seizures. A seizure occurring in childhood more than 1 month of age. So you can imagine that only the neonates are excluded here. And there's no upper age limit, right? Associated febrile illness not caused by an infection of the CNS. So obviously you need to exclude your CNS infection or meningitis by examination, and without having any neonatal seizures or a previous unprovoked seizure, and not meeting the criteria for any other acute symptomatic seizures. Like acute symptomatic is where there is some, like, acutely if he's having some insult in the brain. So this patient is, according to the ILA definition, falls into the febrile seizure. So febrile seizure is the most common seizure disorder in childhood. So you know that many children present with this and generally have an excellent prognosis. They may, although they signify a serious underlying CNS infection, but most of them are benign. And they occur from 1 month. But commonly, if you look at your textbooks or if you go for your lecture notes, sometimes it's commonly 6 months to 6 years. So that is the common age group that we may encounter these patients. So that's why it's easy to remember also 6 months and 6 years. However, beyond 6 years, if we have a seizure with fever, still you don't call it epilepsy because it's provoked. And also if he has had past history of febrile seizure, obviously that is taken taken as a febrile seizure group, right? And the strong family history of febrile conversions in siblings or parents are there in most of the patients, which suggest a genetic predisposition. And of course, going further, they have mapped several genes which in patients with febrile seizures, and that is quite, and mostly in the 19p and 21, but there are many other genes that have found to date. So when we look at a febrile seizure, we know that we divide it into two types, that is the simple and the complex febrile seizures. So simple, as in our child who presented to the ward, generalized, and it's lasting less than 15 minutes, and it's one seizure for one episode, and there's no focal neurological signs. And then complex means it could be focal or still could be generalized, lasting more than 15 minutes, and febrile status epilepticus also includes in the complex variety. And there could be more than one seizure for one febrile episodes, meaning if the patient comes today with a febrile seizure, and then there may be many other seizures occurring in the same febrile episode, maybe mostly it's 2 or 3, but some may go on to have like about 6 or 7. So that is the complex febrile seizure. And also they may have presence of focal neurological signs like a weakness or something like that. So that is the differentiation. And then I thought I'll put this as well, a symptomatic febrile seizure or a seizure precipitated by fever. When the child has a pre-existing neurological abnormality. Now you can imagine with the definition, we cannot call it a febrile seizure. Therefore, there is a symptomatic febrile seizure, or if there is a pre-existing neurologic abnormality, or if there is acute illness, then you can call it a symptomatic febrile seizure or a seizure precipitated by fever. So that's another terminology, but it is not belonging to these two categories, right? Hope it's clear. And then the main concerns that we have is on managing the parents of these children, because they are really worried about the short-lasting seizures that happen. And we have to advise the parents on initial management of febrile seizures at home. So you have to protect the child from injury during the seizure, right? And you should not restrain the child or put anything in the mouth. That's a very important thing, because most of the parents go and put spoons or sometimes their own fingers just to prevent the tongue being bitten. And also they try to restrain the child as well, which may cause more harm. And better to turn the patient on the left lateral side or in the recovery position. And especially when the seizure stops, it's always better to keep the patient like that. And also we have to tell the parents that the child may be sleepy for up to about an hour, because the post-ictal period is very minimal. Mostly they wake up after about 10-15 minutes. And then if it is the first febrile seizure, like in our child, you have to seek medical advice, even if it is lasting less than whatever the time that we mentioned for a simple febrile seizure, because you know that we need to exclude infection, especially in the first febrile seizure when it occurring in the infancy. And also bring to hospital if the seizure continues for more than 5 minutes. So the 5-minute timing came in because now the status epilepticus definition is 5 minutes of generalized tonic-clonic seizures. More than 5 minutes means that it can damage the brain. So that is why the 5-minute cutoff came, right? And for a recurrent febrile seizure, you can administer rescue treatment for the seizures if they last longer than 5 minutes, especially the tonic-clonic component. If they are just, staring, it doesn't need to, that's what the literature says. It's mainly the tonic-clonic seizures that you need to continue, restrain after 5 minutes. So it could be either a rectal diazepam or a buccal midazolam or a nasal midazolam as the first line treatment in the pre-hospital setting. But of course, when you are giving this to the parents, you have to be very careful, because diazepam or lorazepam or midazolam or whatever can cause respiratory depression in whatever the route you give. So therefore, you need to educate the parents on how to give the basic life support. And also, if there is a hospital or a medical attention close by, then it's fine to give this. But otherwise, you have to select the patients very carefully. So the other thing the parents ask you is, how do you prevent this? And even for the clinician, that is a very important thing, how to prevent. Is there any way of preventing this? Well, there's no advantage in the use of intermittent brufen, diclofenac, paracetamol, or placebo. So that has been tried versus placebo in preventing further seizures. So obviously, there is a chance that the child can get a febrile seizure. It's about 30%, they say. And there's no advantage in the use of ibuprofen, diclofenac, which we have to clearly inform the parents, because otherwise they come back and say, doctor, you gave us paracetamol. You asked to give us paracetamol, but still my child is getting seizures. So they are not very happy. So you need to communicate this to the parents. And also, there is no evidence for prophylactic antiepileptic drugs in prevention in simple febrile seizures like sodium valproate or phenytoin or any other anticonvulsant. Has not shown any evidence in prevention of recurrent simple febrile seizures. I stress here it's simple febrile seizures, right? Because the risk of a simple febrile seizure and risk of side effect of the drugs, you have to, when you weigh the balance, the risk of the side effects are much more. And also, some studies have shown that oral diazepam has been shown to reduce the recurrence at 6, 12, 18, 24, and 36 and 48 months. But the usage of such drug has to be clearly defined, again, with the risk versus the benefit. So these are like from some of the studies that I have taken these details. Okay, so that's about febrile seizures. Now we'll move on to the case scenario 2. Mother brought her 6-month-old baby to the clinic with abnormal movements, flexor and extensor movements, both arms, followed by a cry, right? She brought a video of the events. The baby was born by an emergency section and had an APGAR score of 1 minute 0, 5 minute 5, 10 minute 6. So that means that there had been some insult at the brain. There has been some birth asphyxia. He was managed in the SCBO for 1 week. Currently, he does not have proper head control and no social smile. So there is a delay in his development, 6-month-old baby. So if I show you this video, I hope it's running well. You can see that this child having some extensor spasms with eyes going up and then some discomfort in the mouth.
He's doing it. He only does it for a couple minutes. So
okay, so what is the diagnosis? And name one investigation to confirm your diagnosis. And how would you treat this? And what are the important considerations that you have to check? Okay, so this is, if you have heard about West syndrome, it's the epileptic syndrome. So this is the epileptic syndrome that is characterized by the triad of infantile spasms, hypsarrhythmia, that is a EEG pattern, and arrest of psychomotor development at the onset of the infantile spasms. Or I'm adding one more thing, that the delay of development could be there from the beginning. So, and 2 of 3 is needed for the diagnosis here, right? So types of infantile spasms could be flexor. What you saw is an extensor type, and it could be mixed as well. And then when you consider the etiology, there is a vast majority, it's about more than 90% are symptomatic. That means there had been some abnormal neuro or mental development prior to the onset, like in this child who didn't have any, who didn't have any head control or who didn't have any social smile, and evidence of brain lesion on the clinical or neuroimaging. So you can see the reasons: neurocutaneous syndromes, brain malformations, metabolic causes, infections, HIE. All these are causes for symptomatic infantile spasms. Then there is another etiology, which is cryptogenic, or where we cannot find a cause despite most of the investigations. So it is about 10 to 15%. So there's normal neurodevelopment and no cause identified, but they have a better prognosis. So with the semiology of the event you saw in the video, they are very brief. several spasms occur in a cluster, and mostly bilateral these are, but then rarely it can be unilateral also, and many clusters a day, and occur in times where the baby is mostly drowsy. That means when the baby is very sleepy, right? So EEG is the mainstay of diagnosis. So this is the EEG with a very chaotic pattern. This is the typical of hips arrhythmia that I'm showing you in this EEG. And sometimes a long EEG would be needed if you don't show these changes. Right? So management includes steroids, that's the prednisolone. There are various regimes used in different trials. We use prednisolone in our country mostly, and ACTH also used in intramuscularly. And also vigabatrin is another drug which is said to be the first line in tuberous sclerosis. We know that most of the tuberous sclerosis patients have infantile spasms. So this is most likely the first line in tuberous sclerosis. But of course, the side effect is retinal damage, which is irreversible in 30%. So that is a concern. And then the other drugs like sodium valproate, tropidamate, and lamotrigine can be used, but this is after the initial treatment trial with the steroids and the vigabatrin. So one important thing, cautions while on steroids. So when you're on steroids, this is a very high dose that we use. So you need to monitor the blood pressure and the capillary blood sugar every 2 to 3 days. This is a small baby. We are using like about 40 milligrams of steroids per day. And there's increased risk of infections, which you have to tell the parents not to go to the crowded places. And the chickenpox is a deadly infection in these patients if they are on high-dose steroids. You know about steroids. So you need to treat them early, or if they're in contact with the chickenpox, better to get into the hospital so that we could give specific immunoglobulins and treat these patients. And no live vaccinations, example, oral polio or MMR during this treatment time. And JE vaccine, the Japanese encephalitis vaccine, should not be given at 1 year because this is an evolving neurological problem, and JE vaccine is a neurotropic vaccine. Therefore, we try to delay it as much as possible if the child is still having seizures. And prognosis-wise, it's variable. The cryptogenic infantile spasms obviously has the best prognosis, and the symptomatic infantile spasms, a proportion may continue to be encephalopathic and having seizures continuously, and they may become intractable. And this is where the Lennox-Gastaut syndrome comes into place. That is like a graduation from the infantile spasms, the worst scenario. So I'm not going to discuss on that because for the undergraduates, I don't think it's very relevant, and it's a very specialized management anyway. So case scenario 3, an 8-year-old girl is brought with a history of not attentive in the class for the last 2 months. The mother claims she also notices the child goes to, she is not responding to her commands and on and off, and thought that it was a usual age behavior. But over the last few days, mother noticed that the girl is staring for a few seconds while doing her homework and at meal times. So when inquired, she replies back and continues on the pre-event task. So mother didn't really take any notice. So there is no loss of posture during the events, and clinical examination is unremarkable. So childhood absence epilepsy. It's a general. So this is the classic picture of childhood absence epilepsy, generalized syndrome. It's a genetic, presumed to be genetic. And the age at which it presents is about 4 to 8 years, and commonly 6 to 7-year-olds present in, that is where the school teacher picks them up. And they are very frequent and brief for a few seconds, the seizures or the staring episodes, and there's no loss of posture and continues on the pre-seizure activity. And the typical EEG pattern is 3 per second spike and wave activity, and that can be precipitated by hyperventilation. Most of them are treated well. But however, some may go into other generalized seizure types. So just a quick video about absence seizures. Just concentrating this girl.
Teddy bear, show your shape. Teddy bear, well, it's me now. No, it isn't. Yeah, it is.
she has very brief, unresponsive
No, it's
episodes.
already now the second daughter's
Just
after
1 or 2
Adele.
seconds.
Isn't that right, Adele? My birthday's after yours. Yeah? Am I not next? No, you. Sure said you were chasing Jack Garrett. I'm in the rope, Ken. I had a little puppy. His name was Tiny Tim. You're at my turn. I still got
So
out.
you
It wasn't
saw
me.
that she briefly goes out, and then this is the typical EEG pattern. This is 3 spikes and waves within 1 second in the EEG. 3 per second spike and wave activity, which is precipitated with hyperventilation in the EEG. So the treatment options are ethosuximide, valproate, and lamotrigine. I think earlier it was ethosuximide was mentioned as the first line in older books, but now all 3 have come into play. So any of these can be used as first line. But you have to make note that carbamazepine and vigabatrin can cause worsening of absence epilepsy, so you should not use them. Right. Moving on to case scenario 4. A 9-year-old boy is brought with a generalized seizure occurring 1 hour after going to sleep. Brother who witnessed the seizure had saw him rising from bed, mouth division to a side, and excessive salivation followed by generalized tonic-clonic movements. The boy says he was initially aware of the mouth division and tried to talk but could not speak. He has no past history of any seizures and had been neurodevelopmentally normal with good school performance. The clinical examination here again is unremarkable. So the EEG in sleep revealed a spike and wave discharges. I don't know if you can appreciate this. This is in one side. So this is the left side, temporal, frontal, and the frontal, central, and temporal discharges, right? So the diagnosis here is epilepsy with centrotemporal spikes, or benign Rolandic epilepsy, as we used to call it earlier, but we don't use that term anymore. But epilepsy with centrotemporal spikes is the name that we use now. So it occurs between 2 to 14 years, but peak age is around 10 years. Unremarkable history, usually normal. And the seizures are focal, but mostly we see, at least the parents see the latter part of the seizure. So once they're generalized only, they see. But if you watch from the beginning, it's mostly confined to face. Occur in sleep, usually as soon as they go to bed or waking hours. And they may have guttural noises like the noises from the throat, dysphagia, and excessive salivation. And the consciousness may be preserved initially, but may not be able to talk. And then proceed to secondary generalization, most of them. And then most of them have very much lesser number of seizures, like every 6 months or 1 year or so. Therefore, we do not attempt to treat this because it's a self-limiting epilepsy. But however, if there are frequent seizures, we need to treat them. The drug that we use can be decided with the EEG findings. Most of the time, it may be carbamazepine as it starts as a focal, but it could go into valproate as well. Okay, so case scenario 5. Is a 2-week-old baby brought by her mother with jerky movements of limbs occurring in sleep. When the baby is awake, there had been no movements. The baby is well, active and feeding well with a good weight gain. On further questioning, there is no involvement of the face. Mother brought a video for the consultation. So this is the video. You can see that the baby is nicely sleeping and both limbs and legs and arms are moving, and I don't know whether you can appreciate there's no facial movements there. So this is a benign sleep myoclonus. I just put this because this is a differential for myoclonic epilepsy, but some people may start treating this unnecessarily. That is why I put this video. It always occurs in sleep and never arouse the baby, never involve the face. So there are many, 2 nevers and 1 always. And if the patient is aroused, if you arouse the baby, these movements disappear. Right? It's called a movement disorder, benign sleep myoclonus. But of course, you have to keep in mind that myoclonic epilepsy can present like this, so you need to be very careful when assessing these babies. And I thought, like, not as cases, but important seizure mimics in children that comes to the private or the GP setup or in the hospital, which many doctors treat as epilepsy. So this is one such thing. He is very irritable. Observe that his mouth turns blue and he stops breathing. And you can see the mouth opens. And there is a tonicity, tonic movements, right? So you need to, once the baby is stimulated, it comes back. So this is not an epileptic event. This is a non-epileptic event called the blue spell. And then right, move on to the other one.
And partly hidden in the toy ring slumps down. When lifted out, the child is floppy and has the typical twitches we have seen in other induced syncopal events. If this stage is reported in isolation, it could easily be misinterpreted as an epileptic seizure.
So where this child is more pale and where they are very limp. Okay, so reflex anoxic seizures, as we call it, or breath-holding spells, is transient hypoxia to the brain, and it's common. 4% of children aged less than 4 years could have it, and blue spells and pallid spells. In blue spells, the child is mostly anger and in frustration, and they cries and hold the breath, and cyanosis with either loss of consciousness, or it could be like preserved consciousness also, and few jerks later. Pallid spells, it occurs due to trivial pain. It doesn't have to be a major pain, just hitting very simply would cause this. And no initial distress. They may be playing and they will be pale and loss of consciousness, and you can have jerks again. So in summary, febrile seizure is the commonest seizure disorder in childhood. Early treatment of West syndrome is important for better outcomes. So detect them or suspect early and referrals to be arranged appropriately. And childhood absence epilepsy is a treatable epilepsy. You need to be careful in identifying the absences or the staring events. Mostly the teachers are the people who complain to the parents. And epilepsy with sensotemporal spikes is a self-limiting epilepsy. So the necessity of treatment only if the seizures are frequent, unless you don't have to treat them. And benign sleep myoclonus does not need any treatment. It settles by its own by about 4 to 6 months in some patients, or even earlier. Blue spells and pallid spells are mistaken as epilepsy, and careful clinical evaluation is necessary. So it's just, I didn't cover the whole lot. There is many more, but since given the time and also in the undergraduate curriculum, we concentrate on these few topics. So that's why I covered them. So let's move on to the questions. I think, Vihanga, are you ready with the poll? So you have to select the best response, right? So question 1, a 14-month-old boy is brought with a generalized seizure lasting 2 minutes. The postictal phase is brief and he wanted to play. His development is age appropriate. His mother has seizures in childhood. 101 degree Fahrenheit fever was detected 30 minutes after the seizure occurred. So in this child, this fever detected after the seizure, about 30 minutes later. He has no meningism. That means there's no evidence of CNS infection on examination. Apart from a mild cold, rest of the examination is unremarkable. So what is the most appropriate management option to be carried out? start on oral diazepam, administer a stat dose of diazepam, perform a lumbar puncture, arrange the CT brain, observe the patient for further convulsions. Okay, I think we can stop the poll. I think you have got it correct. This is a febrile seizure. So obviously, you don't have to start on oral diazepam once the baby has had a seizure anyway, and administer the stat dose of midazolam is not necessary because he's not having a seizure right now, and it's a short-lasting seizure anyway. And performing a lumbar puncture is again not necessary because he's very well. There's no meningism, and we can observe. And CT brain is not necessary, and observe the patient for further convulsions is the answer. So let's move on to the next question. A 5-month-old baby is brought with a flexion of the movements, extension movements of the head and upper limbs, and he was in the SCBU for neonatal meningitis. What is the best investigation now to arrive at the diagnosis? The investigation I'm asking: electroencephalogram is the EEG, MRI epilepsy protocol, CSF lactate levels, urine organic acids, genetic studies for tuberous sclerosis. Okay, I think it's a very easy question. Okay, so the answer, most of you have got it correct. It's the EEG, where you get the hypsarrhythmia in this baby. And all the other investigations may be necessary at a later stage, but to arriving at the diagnosis for this particular situation, the EEG is the mainstay. Right, question number 3. Now, this 10-year-old girl is admitted following these events in the class. Also the class, he has not completed her books, written work in the books over the last 3 weeks. And the grandmother, she had lost her grandmother 2 months ago. And her father is a drug addict. And she had a lot of problems at home. Birth and development is normal. And there is recent... and also the examination is unremarkable apart from the recent deterioration in schoolwork. So what is the most likely diagnosis here? Daydreaming, hypothyroidism, generalized epilepsy, depressive illness, substance abuse. This may be a little tricky, the way that I have put this question, because you have answered all easy questions. So this is a bit of a difficult question. So I think, we can stop the poll now. Okay, so I'll discuss it. So I think most of you have got depressive illness, but if you have gone through the history again, and it's a 10-year-old girl who came with staring episodes, right? And teacher is the one who notices this. And also he has not completed her work, because if she is getting recurrent staring episodes, she is unable to complete the work. The grandmother dying and the drug addict, I purposely put to add flavor to the story. And the recent deterioration is a presentation of absence epilepsy, childhood absence epilepsy. That's why I purposely put this question, because that could be a presenting feature of absence epilepsy, although we don't think about it. So daydreaming is like, some patients daydream where various reasons, and hypothyroidism, poor school work, yes, possible, but they don't have staring events. And generalized epilepsy. Now, childhood absence epilepsy is a type of generalized epilepsy, right? I haven't put it in word, but that is the answer. Depressive illness, yes, you may have thought like, okay, the grandmother had died and, he's not doing all work. But of course, you have to go into the history and the age and everything. And then substance abuse, again, because of father is a drug addict. In all 5 conditions, this can happen. But given the history and all the things, it's the most likely thing is the generalized epilepsy, that is the childhood absence epilepsy, right? I haven't put it in that word. So you have to be careful when you are getting MCQs. You may be trapped at some point, right? So question 4, 13-year-old boy, do I have enough time, madam? I have 2 more to go.
Yes, Saraj, just gone.
Yeah. Okay. The 13-year-old boy presents with drooling of saliva and then jerks in his right upper limb in the morning, and he has noted to be drooling. And he had these guttural noises, and mother rushed to the room. Event lasted 10 minutes, and the examination is unremarkable. So, and he was able to remember everything happened. So what is the best management option here? Comments on carbamazepine, arrange a MRI scan, reassure and observe, referral to an ENT surgeon, and perform investigations to exclude a vascular event because he had a focal change or jerks in the right arm. Okay, I think we'll stop the poll there. So most of you have got the correct answer, reassure and observe, because this is a clear-cut history of a benign Rolandic epilepsy as the old term, but epilepsy with centrotemporal spikes, drooling of saliva, inability to speak and jerking of the right, because I said it's a focal epilepsy to start with, and he was able to remember everything. And the guttural noises or unusual noises that we heard, the mother heard, was due to the vomiting and the nausea, retching type of history. So the answer is 3, reassure and observe. All the others, comments on carbamazepine, we only start when it's recurrent. An MRI scan, again, if there are any suggestive features or suspicious features. And referral to an ENT surgeon, I put this because of the noises that we heard from the throat, and perform investigations to exclude a vascular event because it was a focal event that we initially noted. Right, the last question. A 2-year-old boy was brought with an event where the boy went blue and started following an excessive cry with the fight of the brother. In the past also, he has had temper tantrums with similar episode. The episode lasted 2 minutes, and his development age appropriate and normal examination. What is the best description for this presentation? Vihanga, can we change the poll? Pallid breath holding spells, cyanotic breath holding spells, tonic seizure, cardiac syncope, and cyanotic heart disease. So he had become cyanotic. Okay, we'll stop the poll now. Yeah. I think most of you have got the correct answer. Cyanotic breath holding spell. As I mentioned, cyanotic and pallid breath holding spells are occur in two different circumstances. So here it's a baby who cries and, crying excessively and being very angry and frustrated. So, and also he becomes cyanosed. So the name is there, cyanosis. Right. So I think it's an easy question again. I think that ends the quiz and my talk. So thank you very much for your patient listening. And if there are any questions and if there's any time, I'm happy to answer.
Thank you, Saraji. Thank you very much for that excellent presentation. I think that you made it so easy for all the students with illustrations. I don't think that they would be left with very many questions, but then all the time there are so many questions. So if I try to move from up, how do you diagnose a condition like tuberous sclerosis with only one unprovoked seizure?
Yeah, well, it's not with the seizure. So tuberous sclerosis, I mentioned, I didn't talk about tuberous sclerosis because if I started talking about it, then obviously it would take the whole time. Tuberous sclerosis has many other skin manifestations like the ash leaf macules, the Charcot patches and periangular fibromas and subungual fibromas. So there are many other cutaneous features to go by. And also your echocardiogram will find that there may be a cardiac rhabdomyoma and eye changes. So there are a lot of things to diagnose the tuberous sclerosis. I just mentioned the word tuberous sclerosis, but I didn't go into that. It's not only with one seizure, but tuberous sclerosis is more prone to get epilepsy. So that's what I said. If you diagnose in a patient, that as an example I gave, then you know that as it is more prone to get epilepsy, so then there is a prediction that he may be having more seizures later on.
Thank you, Saraji. The next is that you said that there should be 2 seizures 24 hours apart to diagnose epilepsy. Is there an upper limit for this duration to diagnose? Can gap between 2 seizures be a few years?
Yes, I think that's correct because this is the minimum, right? So if it has to be 2 unprovoked seizures, gap has to be at least 24 hours and it can be 6 months or 1 year because we see patients who come with the first seizure before and then coming after 6 months or whatever the time afterwards.
Thank you. Do we have to admit a child with first seizure to exclude latent provoking factors or can he be reassured and sent home?
I would suggest if they are in infancy, it's better for you to admit the child with a febrile. I believe that it's the first seizure that you're talking about. Most likely it's a provoking seizure or it depends. I mean, it could be still the first episode of epilepsy, but especially in the infancy and if it is associated with fever, it's necessary because you need to exclude a CNS infection which may have gone undiagnosed. But if it's the second one, obviously we know that he has a tendency to get febrile seizures.
Does infantile spasm by itself cause any damage to the baby? If it does, is the benefit of treating using high-dose steroids having more benefit than the side effects?
Yes, like the infantile spasms is the encephalopathy. So basically, most of the babies would have neuromotor regression. So unless you treat this, they cannot come out of this encephalopathy. So I think you're talking about the cryptogenic, who asked the question, where there's no abnormality in the brain, but there are some, some reports saying that it's self-limited, but most of the patients that we see, and even in the literature, they say it's to treat them vigorously with the high dose of steroid, but it's a very short lasting. I mean, it's only 2 weeks of treatment of high dose so that we come down very rapidly on the steroid dose afterwards. So once we hit it clearly, the encephalopathy, then the child comes back to normal. Obviously, the side effects are mainly the gastritis and things like that we see, and we haven't noted any deaths as such.
Just if you could just summarize the management of febrile seizures again, I mean, just summary.
Yes, so management is like in febrile seizures, obviously you need to find out the cause for the underlying fever. If it is CNS infections, then you need to treat the meningitis or encephalitis. Otherwise, if it is just a simple febrile seizure, you have to reassure the parents and tell them, mainly advising the parents on the next episodes or the repeated episodes. There's a 30% chance of getting a recurrent episode. So you have to say that there could be a chance, and then what to do when a seizure happens, and that none of these medicines like paracetamol, diclofenac, or whatever you give will not prevent. There's no report to say that it prevents. And I haven't mentioned here actually about the cold water and sponging. That also has no effect. So therefore, basically what we need to tell the parents is, look here, your child is going to get another seizure, but you have to manage the first aid. Basically, it's the first aid, not to put anything, not to restrain himself, and that sort of first aid, and try to turn to a side to prevent the saliva or the froth going backwards. And if it's lasting more than 5 minutes, to get to the nearest hospital or the medical attention. I hope that is enough. Yeah.
Thank you, Saraji. Some lot more questions. How do we differentiate juvenile absence seizures, juvenile myoclonic seizures, and childhood absence seizures?
Yeah, okay. So all these are epilepsy syndromes. So childhood absence seizure is the one that I described here because it's pediatrics, and juvenile is a little beyond my territory. But juvenile absence is, it's mainly according to the age, the absence. So it's if it happens around 13 or 16 or above with the similar kind of features, and their EG findings are also slightly different to childhood absence seizures. Like they may have rather than 3 per second, they may have 2.5 or 2 per second, like that. So that's the difference in juvenile absence. And then myoclonic seizures are a different entity altogether, which I haven't discussed because we see mostly after about 14 years. In that situation, they have jerks, myoclonic jerks, very brief seizures, especially starting in the morning hours when they wake up, and they have difficulty in carrying out their day.
Recording in progress.